Good morning, everyone. Welcome to Singapore Cancer Society's Lung and Prostate Cancer Awareness Webinar 2024. I'm Annie, your host for this morning. We would like to thank our sponsors, Daiichi Sankyo, AstraZeneca, and Bayer for supporting the webinar today. Before we begin, let's start with a quick introduction about Singapore Cancer Society. Established in 1964, Singapore Cancer Society is a self-funded social service agency which provides patient care services to patients in need through its cancer treatment subsidies, welfare, rehabilitation support programs, and hospice care. In addition, Singapore Cancer Society also provides free cancer screening services and promotes cancer awareness and prevention through its public education and community outreach program. For today's webinar, we have an online live poll throughout the session. Do join us by responding to our poll. Shall we start our first question? So our first question is, lung cancer can only affect men. True or false? Okay, we have answers coming in. Wow, we have more than 100 votes now. Let's see. Okay, so here we go, the results. We have 118 people voting online, and 99% of them thinks that it's false. Yes, that's correct. Answer is B, lung cancer affects both men and women. All right, second question. Which of the following do you think is the most common occurring cancer found in Singaporean men? 3 choices: colon rectum cancer, prostate cancer, and lung cancer. Which is the most commonly found among Singaporean men? Okay, we see answers coming in now. Okay, we have our results. So 22% of us think that it's colon rectum cancer, 69% thinks that it's prostate cancer, and 9% thinks that it's lung cancer. The answer is B, prostate cancer, and it's also the cancer that we're going to deep dive today. Now we're all warmed up. In case you have any question during the webinar, please submit them by clicking the center icon in the bottom of the screen if you're on Zoom, or send it in the comment section on Facebook. We will try to answer as many questions as possible during our Q&A session. Now, without further ado, let's welcome our guest speaker for today. Besides me, we have 2 doctors. We have with me Dr. Jens Samuel, Senior Consultant in Medical Oncology at Tan Tock Seng Hospital. He'll be sharing with us more about lung cancer. And next to me also, we have Dr. Tan Teck Wei, Senior Consultant Urologist at TTW Urology. He would focus on prostate cancer. As we start the fire chat session, let's start with a poll that's related to lung cancer. Can we get a poll up, please? Okay, lung cancer is often depicted as a smoker disease. I won't get lung cancer if I don't smoke. Is this true or false? Wow, looks like everyone knows the answer. Okay. Few more seconds to go. Okay, we have the results up. 99% responded that it is B, it is false. Even if I don't smoke, there's a chance to get lung cancer. Is that true, Dr. Jens?
Yes, it is correct. So it is fantastic to see that the audience is so knowledgeable. And yes, it is correct. Unfortunately, smoking is not the only cause, a big cause, but it's not the only cause for lung cancer.
So, Dr. Jens, as we continue with our fireside chat, what exactly is lung cancer?
Yeah, thank you very much for this question. And I have prepared a small talk or slides. And it's just to help myself remember what I want to tell you. And we are starting with this first slide. I hope you can see this. It's basically, this is the Lung Cancer Awareness Month as well as Prostate Cancer Awareness Month. And I'll be starting to talk about lung cancer. I'm one of the medical oncologists at TTSH. I have a affiliation to the Li Kongqiang University, NTU, as well as to Johns Hopkins University in the US. And the talk is about lung cancer today. So where does lung cancer come from? Essentially what you can see in this slide is that it originates or comes from the airways and what we call pulmonary parenchyma. Now this is a big word for essentially lung tissue. So the trachea or the windpipe is the big sort of tube you can see at the top of the slide, diverts into the right and the left lung and branches out a little bit like a tree, or the branches of a tree into the right and the left lung, supplying the lung tissue, which is in the sort of darker color, for gas exchange. Gas exchange essentially means oxygen goes in and CO2 or carbon dioxide goes out. And this is the main function of the lung, to supply our bodies with oxygen. And any of these cells that do this sort of, or have this function, can become cancerous essentially. So that's where lung cancer comes from as a sort of, as a cause of it. The cells go wrong. If we dive deeper into some statistics, and this is what this slide shows you here, it's taken from the WHO classification back to 2015, but still pretty valid. We divide lung cancer into cells, and they will look different under the microscope, and most of them are, or the histologist, or the pathologist looks at them and says it's small cell because they look small, as opposed to non-small cell. And the non-small cell type are the ones that are more common, of which we have different pathologies, which I'm not going to go into, but they may have different sort of underlying causes as to why they've come about. And the cartoon on your right-hand side shows you colorful way the percentage of small cell lung cancers as to non-small cell and the different histological cells that may have gone wrong in conjunction with smoker and non-smoker. This slide is there just to show you the advances within what we call advanced non-small cell lung cancer. About 24 years ago, lung cancer was one big sort of disease, non-small cell lung cancer. And then we realized that the cell that has gone wrong in the lung is important, and then we managed to sort of distinguish between squamous and non-squamous, and further on we found what we call mutation, which are biomarkers. The most common of these biomarkers of mutation is EGFR, very common in this part of the world. Up to 50% plus of the lung cancers in non-small cell adenocarcinoma type is caused by this or driven by it. And then from 2011 onwards, we found a lot more of these biomarkers. One of them are called ALK and so forth. They are not as common, but they are important pieces of information that we would want to know. You may have heard about immunotherapy. Immunotherapy is a different type of targeted treatment or biological treatment that is important since 2011. And then at the bottom end, we still have the histological types, which are still important in terms of deciding chemotherapy combinations. So these are the advances we've had. And coming back to the causes of lung cancer, we said the cells are important, but smoking is still important, or a big cause of lung cancer in about up to 85%. There is this what we call second-hand smoking or passive smoking in about 5%. And then we mentioned the non-smokers. 10% is what some publications or institutions sort of say, but we know that it actually is probably higher than that and can be as high as 25%, because you guys have already voted, and you know that smoking is a cause of lung cancer, but it's not the only one. And I've mentioned the EGFR mutations or biomarkers, and they are the reason why in non-smokers lung cancer can occur. So I need to talk about smoking. Smoking is big business. It's lots of billions of money, and there's about 5.5 trillion cigarettes sold every year, despite all the knowledge that it is bad for us. It is also now being pushed that there are these what we call the e-cigarettes, or the electronic cigarettes, the vapor products called next generation products. Sounds all very exciting, but essentially it's the same thing. It's hooking people onto something that we don't want. So is vaping better than smoking? And the answer is probably not. Yes, you have more flavors, as you can see on the picture on the right-hand side. What should go into the lungs, however, is just oxygen and carbon dioxide to come out, not this sort of vapor you can see in your left-hand side. So e-cigarettes, basically what they are is you inhale heated liquid, and these aerosols go into your lung. Yes, the nicotine is the bit that maybe people want, and it can be addictive, no question about it, but we also inhale ultrafine particles that get stuck in the lung, cause diseases. The flavors are linked to chemicals that also can cause serious lung disease, and the volatile organic compounds are also not something we should actually have in our lungs. In addition to this, vaping is known to sort of have the same cancer-causing chemicals as in the traditional cigarettes. So there is no difference. So there is more evidence coming out that actually vaping may also cause lung cancers. And heavy metals like nickel, tin, and lead should also, it's in there. It shouldn't be used as. And there's this condition we call EVALI, which is e-cigarette or vaping product use associated lung injury. It's a mouthful, but essentially it encompasses all these issues that vaping brings with us. I want to highlight that Singapore aims to reduce smoking rates. And in 2020, the smoking rate was about 10.1%. It was meant to go below 10%, but 10.1% I think is a pretty good achievement despite the pandemic at that time. I would also like to highlight that vaping is illegal in Singapore, and I believe that is for a good reason. Just to quickly highlight to all of us, smoking is not good for lung, or it can cause us lung cancer, but it also causes heart attacks, stroke, chronic obstructive lung diseases essentially, and these are underlying reasons or causes for lung cancer. And it also leads to a quite increase in the direct healthcare costs for all of us. So having said all this, I come back to causes of lung cancer other than smoking. And there are quite a few. There is this, what we have realized over the years, familial lung cancer risk factors. There is an increased risk of lung cancer if it is in a family. We are not quite sure why that is, but it may just be exposure to the particular occupational exposure or environmental exposure as shown over here. So for occupational exposures, we have asbestos as the biggest cause for it, causing a different type of lung cancer called mesothelioma. Environmental exposure, radon is a natural gas. One can test for it if you want to, but it is ubiquitous somehow in the natural world. And air pollution. Air pollution is something we in Singapore can't avoid. And it may be better to sort of redefine air pollution into dust, which are nothing other than flying particles of multiple origin, and road dust is one of them, which is probably quite prevalent here. Now, there is some evidence now that wood burning can cause lung cancer, and later on in one of the slides I will mention a sort of trial that is running to screen for lung cancer. We know that in cooking fumes sometimes are also incorporated or thought to have caused or a cause of lung cancer. Vitamins are mentioned down here, so beta-carotene, excessive amounts of it should not be used. It is a known cause of lung cancer, so avoid excessive vitamins or this sort of health products that are promoted on the internet. They usually don't help. Underlying diseases I've mentioned before, COPD or sort of scarring of the lung can happen too. And if somebody had to have treatment with radiotherapy for other sort of cancers, they have an increased risk of developing lung cancer. So these are quite a lot of causes, and they if there is a lung cancer, most often leads to the same sort of common symptoms. So what are common symptoms for lung cancer? That is a cough that doesn't go away, or instead it gets worse. There may be some blood that is being coughed up, which is a rust-colored sputum in the spit or in the phlegm, and there may be chest pain that may often worsen on a deep breathing, and also may happen when there is when somebody coughs or is laughing. Hoarseness of voice can be, again, over time, it may get worse. The loss of appetite, unexpected weight loss, shortness of breath, feeling tired or weak are more symptoms of a more advanced lung cancer, but they can be symptoms. And then infections within the lungs we've mentioned before. And sometimes wheezing can be also a symptom of that. Now, I'm showing the same symptoms again, and this is not for you to remember. It's just showing you a sort of way as to how we in the healthcare service would address such a symptom. So if somebody has a cough of 3 weeks or more, then he goes and sees a GP or polyclinic, and then certain investigations will be done, the history will be checked, taken, physical examination, maybe tests will be done, chest x-rays, and from there on there will be sort of a pathway being started to make sure we're not missing there is a lung cancer or something different or something other sinister. So this is just to show you that there are pathways in place how to investigate this. Lung cancer, like many other cancers, unfortunately can spread to other parts of the bodies. It can spread to the bones, causing pain due to fractures. It can spread to the nervous system, to the brain, causing some sort of headaches or other symptoms. It may infect the liver, making the skin turn a bit yellow, or it may just lead to swelling of the lymph nodes, which at lungs are part of the immune system. I'll mention these quickly. These are specific symptoms that can cause specific complex symptoms, which we may or may not have, but I'm actually going over these quite quickly because they are not of big concern for us. It's the common symptoms, and this is mainly a cough that doesn't go away, other persistent symptoms of 3 to 4 weeks or more, and then frequent recurring symptoms or chest infections. And all these symptoms can occur in never smokers, and never smokers or ex-smokers or second-hand smokers. So these are the symptoms to watch out for and not to ignore. So what can we do to prevent it? So measures to reduce the risk of it. And the obvious one is stop smoking, or better not start smoking, and I've mentioned this before. Our lungs are there to exchange gas, oxygen and carbon dioxide and nothing else. This cartoon on your right hand side shows curves that are higher or lower, and essentially if a person who has smoked all his life does not stop, you can see that the risk, and this is for men, that the risk of developing lung cancer is really high. It's the red line going all the way up quite steeply. And then the other two lines show you what will happen to the risk of lung cancer, as in reduction after stopping over years, at what year the person has stopped. And it, of course, goes down. So the sooner one stops smoking, the less the risk of lung cancer. The bottom line is the sort of what we call population risk of lung cancer. So we all have heard about healthy SG, right? So healthy lifestyle is what that means. Exercise, keep your weight under control, get your heart stress to a healthy level. I put down Mediterranean diet. This is just one example of a healthy balanced diet. Vegetables, fruits, reduce alcohol, 1 unit per day, and don't overeat. Yes, I've been told this is what often happens in this part of the world, and we like our food, so don't overeat. And then this is the bit that I'm coming to, the universal screening, which for lung cancer in Singapore doesn't exist yet, but we have a sort of project which is run by Professor Darren Lim at NCCS, and hopefully Tan Tock Seng will be able to participate in this fairly soon. And this is to look into lung cancer screening. So just some data for all of us. Quickly, lung cancer is the second commonest cancer amongst men and women in Singapore. And you see on the right-hand side some sort of data for various different parts in the world, United States and so forth. There is this what we call Asian type of lung cancers, which is not related to smoking, and this is about half of the number of lung cancer, and is often in middle-aged female non-smoking Asian women. And these are mutation-driven. I've mentioned this mutation EGFR before, and this is what this is mainly due to. Unfortunately, there is still a very high mortality with lung cancers, and what we're wanting to do is diagnose these lung cancers at an earlier stage where there is a potential of cure. So more data in Singapore. So it's leading cause in males, third leading cause in females. It is more males than females. Yes, that is correct, but not only males. And the survival rates are given down here, which are quite poor, but I'm not delving onto this. What I would like to highlight is, again, at the bottom of this cartoon over there, is that localized lung cancer has the highest cure rate, and that's why we want to consider doing a lung cancer screen here. And this is worldwide. We do know that if we do what we call low-dose CT, which is using a non-contrast CT scan that just looks at the lung, it's very fast, takes a few minutes, and gives us some sort of better idea of what may or may not be going on inside a person's lung, and is better than a chest X-ray, and can be combined with sputum. So these are sort of different trials, low-dose CT screening trials. One is called the Netherlands, one is called the Nelson, and there are other ones, and they can, this slide just shows you what happens if you do participate as a smoker in these lung cancer screening trials. Low-dose CT reduces the, or actually increases the detection of early lung cancers, and therefore reduces the risk of late diseases. And this is what this slide has shown. So the challenges we have is it's a low uptake. It's only in smokers in a way, because there is no good screening for non-smokers. It may not cover what we mentioned before, family history, or the exposure to cooking fumes, but there is a sort of a national screening program in Taiwan, and this slide shows you a preliminary result of this. It's quite a busy slide, but what essentially it shows you is the positive rate of the low-dose screening compared to family history and heavy smokers, and the detection rate, as well as the what we call positive predictive value, which means is cancer there when the screen says it is there, is what that means, and it's been put into these various stages. And there is a relatively good correlation between the low-dose screening for the Netherlands trial and the other one called Talent trial, but it also highlights that the family history is quite important there to see. And there is a good correlation in early stages. So what we want to do here in Singapore, what this Solstice trial is about, or program is about, to add what we do call blood-based biomarkers to this. So this is taking blood, looking for DNA, looking for the EGFR mutation or other sort of biomarkers that are important that we know can cause cancer in non-smokers. And we want to see how can we combine this. So it's to find early lung cancer cases and combine this with low-dose CT. So this is the last slide, and this is showing this Solstice trial. You have a QR code at the right bottom. This is for people who want to participate, who do not have lung cancer, but who want to see if there's a screening, and can scan this QR code, go to NCCS where it's up and running at the moment. Could you go back, please? Oh, you can still see, yeah. And this is called Solstice trial. So if you do have questions about it, let us know later on. And it is important that we as a society understand these trials are there to help us understand where we are now with the knowledge of non-smoking induced lung cancers, with the knowledge that there are biomarkers. How can we combine this to improve the understanding, as well as to get to the point where we diagnose lung cancer early to cure? Thank you very much.
Thank you very much, Dr. Jens. It's really insightful, and thank you for bringing us some of the latest research and information related to how we can better detect lung cancer, especially in an early stage. And just in case you're interested in participating in the program that Dr. Jens has just mentioned, remember to sign up by scanning the QR code that was previously shown on the screen. Now, let's move on to talk about prostate cancer. We also have a poll before we get started. So let's get a question on the screen. The question is it true that only older men aged 50 and above will get prostate cancer? Is this true or false? You may respond in the live poll. Okay, looks like it's not as one-sided as the previous question. We're closing our poll in a few seconds, so if you haven't voted, please do so. Okay, so according to the poll, 18% of us believe that it's true that only older men will get prostate cancer, and 82% believes that it's false. So Dr. Tan, what's the answer?
So the people who answered false is correct, because although far commonly we see men above 50 having prostate cancer, nowadays we do see some patients under 50, typically between the age of 40 to 50 years old, who can develop prostate cancer as well.
Dr. Tan, prostate cancer is the most common cancer among Singaporean men. What exactly is prostate cancer?
Okay, so I have got some slides to share to illustrate what I'm going to talk about. Let's get the clicker. Okay, so as you mentioned, what is prostate cancer? But before we talk about prostate cancer, let's revisit the anatomy, because there's still a lot of patients who come to see me. They're not exactly sure where the prostate is. So on this picture that you can see, the left side of the picture is the front of a man's body. That's where you can find the penis. On the right side of the picture is the back of the body. That's where our rectum and anus lies. So in the center of the picture, you can see a label saying the bladder. So the bladder is the organ that stores urine in the body. So when you pee, the bladder muscles will squeeze and the urine will pass down the urine pipe or the urethra and come out from the penis in men. So right below the bladder, you can see a small oval or roundish kind of structure, which is labeled as the prostate. That's the prostate gland. So it is part of the urine tract because urine has to pass through the prostate on its way out. But the prostate is also part of the reproductive tract. We can see a second opening at the back of the prostate. This is where sperm from the testicle, there's a tube that connects the testicle to the back of the prostate, and sperm enters the urine pipe through the prostate. So it's part of the urine tract. It is also part of the reproductive tract. So how do prostate cancer form? So it's similar formation to other kinds of cancer. So every day in our body, there are cells that die, new cells form to replace them. Cancer forms when this replacement process goes haywire and there's an uncontrolled growth of these cells, and these cells can spread, and this is what we call cancer. So prostate cancer is divided into stage 1 to stage 4. Stage 1 to 2 cancer is considered earlier cancer, where the cancer is only found within the prostate. Stage 3 cancer is when the cancer has started to come out of the prostate, and unfortunately stage 4 cancer is when the cancer has spread to other organs. So prostate cancer, as per the question previously, it is now the most common cancer in Singaporean men. It is also the 5th most common cause of cancer death here. So how common is prostate cancer? So actually in Singapore, right, every day 4 men are diagnosed with prostate cancer, and every 5 days we have 3 men who will die of prostate cancer. And because we do not still have a screening program for prostate cancer, even now about 1/3 of cases are diagnosed at stage 4, which is considered incurable, although there are treatment options available.
Okay, so Dr. Tan, what exactly increases the risk of prostate cancer?
Okay, so there are a few things. I think as with most cancers, there's no one single factor that will make you get cancer, including of the prostate. But there are certain risk factors that has been shown to increase the risk of prostate cancer. And as per the question, the main risk factor is age, we do see far majority of patients being above the age of 50 years. Family history plays a part. So if you have a brother, uncle, in the family with prostate cancer, or dad has prostate cancer, it will increase the risk of prostate cancer as well. Ethnicity plays a part, especially for men with African descent. They are at much higher risk of having prostate cancer. And there are some genetic factors as well. So one of the well-studied one is this BRCA2 mutation. It is a gene that increases the risk of breast cancer for women in the family. But for the men in the family who are carriers of this gene, we see that they can develop prostate cancer at an earlier age, and they have the more aggressive forms of prostate cancer as well. And we also see that in men who are obese, obesity, being overweight, can increase the risk of prostate cancer.
So Dr. Tan, how can we detect prostate cancer then? Is there any prevention or screening methods that we should act on?
Okay, so maybe I'll talk first about how we can detect or how to find prostate cancer. So usually I would say that if a man comes to see a doctor, sometimes they may have symptoms, although the far majority of early cancers, they may have got no symptoms at all. So previously mentioned, the prostate is part of the urine tract. So a man who sees a doctor for a urine problem may have a risk of prostate cancer. They'll be asked to screen for this. So some of the symptoms of the urine tract, so the two problems that we have to the urine tract is whether we can hold urine and whether we can get the urine out. So if we have issues with holding urine, a man may see a doctor because he has got storage symptoms. He can't hold urine. So typically this can be urgency. Urgency basically means there's a compelling need to pee that cannot be deferred. So these men are scared that they will leak urine. So when they have the urge to pee, they need to rush to the toilet. Secondly, men may have a frequency. And typically these patients, they say that they can't hold the urine beyond an hour or so. They need to visit the toilet more frequently than that. And they may also have nocturia, which is the need to wake up at night from sleep to pee. And if a patient has issues with getting the urine out, they may have problems from the start to the end of urination. So they may have hesitancy, which is where you need to wait for a while before you can start urination. You may have straining, where you need to push before you can start urination. Men may complain of weak or poor urine flow. The urine flow may not be continuous. It's a stop-start intermittent kind of flow. And they may have issues with stopping urination, where when they try to stop, they still have dribbles or drips of urine at the end. This is what I call terminal dribbling. And finally, these men, when they leave the toilet, they may feel that they can't completely empty the bladder. They feel that there's still some urine left behind. So how can we prevent or reduce the risk of prostate cancer? So there is some evidence that diet or environmental factors may play a part in prostate cancer. So one of this is actually a very old study published in 1991, looking at Japanese, comparing Japanese in their homeland in Japan versus Japanese who have migrated to the United States. So Japan has one of the lowest incidences rate of prostate cancer, but in the study they found that for Japanese who have migrated to the States, actually their risk of cancer of the prostate increases exponentially to be quite similar to the Caucasians in the US. So unfortunately, for specific, dietary food substances, there is conflicting evidence about what's good, what's bad for the prostate. And that's why the guidelines from Europe, from America, they don't strongly recommend completely changing your diet to reduce the risk of prostate cancer. But in general, they would say that a heart-healthy diet is recommended. This would include a diet that is higher in fruits and vegetables with a reduced intake of red meat and animal fat. So to illustrate this, this can be found from the Singapore Cancer Society website. These are some of the foods that are recommended and some of the foods that's not recommended for prostate cancer and most cancers, in fact. So diets that are high in soy foods, including soya milk, tofu, and tempeh, pulses food, including kidney beans, chickpeas, lentils, green tea, lycopenes, which is the antioxidant that is found in fruits and vegetables that gives them their color, found in high concentration in watermelon, guavas, tomatoes, papayas. All these are recommended. And cruciferous vegetables, including broccoli, cauliflower, cabbage, Brussels sprouts, and spinach. And fish, they are high in omega-3 fatty acids, including salmon, mackerel, sardines, and fresh tuna. All these are recommended to be part of a diet and be taken regularly in your diet to reduce the risk of cancer. And things to avoid, including a high intake of processed meats, your ham, bacon, and sausages, red meat and charred meat, which are typically found in barbecued meats. These are things which are probably not that good if you want to reduce the risk of cancer. So the last point is with regards to screening for prostate cancer. So we mentioned, if a man visits the doctor and typically if he has some urine symptoms, what would the doctor do if he wants to be screened for prostate cancer? This will usually involve two things. The doctor will put on a gloved finger to insert into the anus to examine the prostate, because the prostate lies right in front of the rectum. So the doctor is trying to feel for an abnormal lump in the prostate. And the second thing that is commonly done is a simple blood test known as the prostate-specific antigen, or the PSA blood test, which can give the doctor an idea of the risk of prostate cancer. So there is some data that prostate cancer screening can be beneficial. The biggest positive study comes from this very big European trial where they recruited 180,000 men from 8 European countries. They randomized them into screening with PSA testing regularly versus no screening at all. So in this big study, they found that in the screening arm or the screening patients, there was actually a 20% reduction in the cancer deaths from prostate cancer. So there is some evidence that prostate cancer in this European study can be reduced, or death from prostate cancer can be reduced by screening. So what's next, right? So if a man is found to have a higher suspicion of prostate cancer, typically from an abnormal PSA blood test, the usual next step is to do a biopsy. A biopsy basically means putting needles into the prostate to take some samples to check whether there is cancer cells under the microscope. And this is a logical next step to diagnose cancer in most organs in the body. So when we do a prostate biopsy traditionally, how do we do the biopsy is that we put an ultrasound probe to scan the prostate. But unfortunately, on the ultrasound doesn't give us high resolution enough images. So the pictures are not clear enough for us to see cancer most of the time. So when we do a biopsy of the prostate, traditionally we would choose typically 12 spots of the prostate to sample, and we hope to find cancer within these 12 spots. But we know that this is not very accurate because cancer may lie outside these 12 spots, and this leads to what we call a sampling error. It's a bit like trying to hit a piñata while blindfolded. You may miss the target. So what has changed in the last few years is that nowadays we have the MRI scan. So MRI scan gives a very detailed look at the internal architecture of the prostate, and now we can often visualize areas that are suspicious for prostate cancer. So when a man gets MRI scan of the prostate, the X-ray specialist or the radiologist will report, if there's a growth in the prostate, they'll give it a suspicion score of between 1 to 5. If the growth is given a score of 1, it's considered a very low risk of having prostate cancer. If the growth is given a score of 5, this growth is considered a very high risk of prostate cancer. And the even better thing is that now we can see better with the MRI, but we have the technology to match the MRI images to guide the biopsy. So we can target these areas for the biopsy, and this leads to a more accurate sampling of the prostate and reduces the risk of sampling error. So for example, I've shown a couple of images, but just focus on where the yellow arrow is pointing. The yellow arrow is pointing to a small black spot within the prostate. So this is seen on the MRI scan. It is small, but if you've done a traditional random biopsy, you may miss this area, but with correct targeting based on the MRI, nowadays we can pick up even smaller areas of prostate cancer. But the other big benefit of doing MRI is that now a lot of men can avoid a biopsy. Right? Previously, you can't tell whether the man has got cancer based on just a raised PSA. You'll be subjecting a lot of men to do a biopsy. But the MRI gives us good confidence. In fact, studies have shown it is up to 90% accurate at excluding prostate cancer, which means that if a man has a normal MRI, we're up to 90% sure that he doesn't have cancer. This man can probably safely avoid a prostate biopsy. So the other development is with regards to how we do the biopsy. So traditionally, the biopsy needle is passed through the back passage or the rectum into the prostate to take some samples. But we know that your rectum is never clean. it always contains some feces there with their own bacteria. So when we do a biopsy through the prostate, through the rectum into the prostate, we can introduce bacteria from the rectum into the prostate. So this man faced about a 2% chance of a severe infection after a biopsy through the rectum. So nowadays, we can offer patients what we call a transperineal biopsy, which is a biopsy done through the skin. And this is the skin between the scrotum and the anus. And because it's through the skin can be cleaned thoroughly. And studies have shown that instead of a 2% risk of severe sepsis, the risk of severe infection after a biopsy through the skin can be as low as less than 0.1%. And that's why, these are from the latest European guidelines. A transperineal biopsy through the skin for the prostate is now the recommended biopsy approach for a man who requires a biopsy of the prostate. And finally, with regards to screening, what do the guidelines recommend for screening? So these are based on the European guidelines. They do recommend screening men after discussion with their doctors. Men from 50 years of age should be considered for screening. Although men with risk factors for early prostate cancer, and these are patients with a family history of prostate cancer, these are men of African descent, they can be screened from an earlier age for about 45 years of age. And while men with the highest risk, those with genetic mutations, especially the BRCA2 mutations, they can be considered for screening at an earlier age of 40 years old. And as I previously mentioned, the next test for a man with a high PSA score is now usually an MRI scan to decide whether he needs a biopsy. So that's how we nowadays would recommend screening for prostate cancer.
Thank you, Dr. Tan, for your sharing. It's so encouraging to see so much advancement in terms of detection, as well as how we can better manage the cancer. So now we are moving to the next session before Q&A, but we also know that we have some caregivers tuning in onto the webinar today. And I would like to invite the two doctors to share with us some tips for the caregiver. Do you have any self-care tips for caregiver, and also tips on how do we care for patients? Dr. Tan, do you want to share first?
Okay, sure. So I think it's important to know that actually a lot of times, it is a very multidisciplinary kind of care for patients as well as the family, the caregivers. And it's not just about the doctor alone. The doctor manages a portion of the medical bits, but there are other parts of the team that is very important to care. So typically in the hospitals, there'll be nurses or nurse specialists who will help to liaise with the family, put them in contact with the other options. So a very strong option that's available in Singapore is actually by the Singapore Cancer Society. They do have a lot of patient support groups, including for prostate cancer. There are prostate cancer support groups where patients can get in contact with similar patients with conditions like them to know more about how they cope. And in addition, Singapore Cancer Society also provides social work as well as counseling services for patients who need it. In addition, for people with financial issues, they do provide financial aid as well. And finally, there is rehab physiotherapy services at Singapore Cancer Society and in a lot of the hospitals to help for caregivers to holistically manage patients.
Thank you, Dr. Tan. And Dr. Yes, do you have some tips to share also?
Yeah, in addition to Singapore Cancer Society, in TTSH or other government hospitals, restructured hospitals, there are medical social workers. Dr. Tan mentioned the nursing team. There are physios, and there is the occupational health team that all together will be able to help a patient as well as the caregivers. And we know that although the patient is the person who has to undergo the treatment and the investigations and all these things, the caregivers are the one who actually support emotional support, or give emotional support, who give their time, who give their, in terms of transport, and also care for the person at home. We in the hospital or in the cancer clinics see the patient for a very limited amount of time. So the support that is surrounding or that is possible to be given and added through SCCS, medical social worker and so forth, is important to tap on. So it's not that everyone has to cope alone and struggle on. It's tap on it, the numbers we give out to call make use of it. There is always an improvement to in terms of information, the patient information leaflets or services. There are apps that are being worked upon. There is a way of improving the information that we can give to patients and caregivers, and just basically ask for it, and don't be shy to ask for this help, because we care for the person as a team, and that team is the hospital team and the family.
Thank you so much, Dr. Tan and Dr. Jens. So now we're going to open the floor for Q&A. Just in case you haven't sent in your questions yet, please now input in the Q&A box. Can we have the first questions up? Okay, so perhaps we can go with the flow, and I'll invite the two doctors to answer the relevant questions. So Dr. Jens, this is a question for you, I guess. Like, may I know how lung cancer spreads to other parts of the body? Is it through blood flow or other mechanisms?
Yeah, it's a fantastic question, and I think the scientific community is still looking as to how does lung cancer spread. So we used to believe it's through the blood, but the answer to that is no. Because why would lung cancer go to the brain, or why would lung cancer go more commonly to the bones? The blood supply is not so clear. It should go to the kidneys or elsewhere. Yes, it does go to the liver, but it is not the blood supply per se, or the vessels. What we think is it's more through the lymphatic system, and it sort of spreads in this way, but it's not 100% clear. But yeah, fantastic question, but not able to answer with certainty, but it's definitely not through the blood.
Okay, and I have a next question that's for Dr. Tan related to prostate cancer. Just now, we've talked about how we're doing prostate biopsy. So what is the possibility of prostate biopsy actually triggering prostate cancer cells to spread out from the inside of the prostate?
I would say that the possibility of the prostate biopsy causing the cancer cells to spread outside the body is essentially negligible. Prostate cancer is not a subtype of cancer that causes this to happen. So it is useful to diagnose a cancer, and no good evidence to show that it will cause it to spread outside the prostate.
Okay, thank you. And the next question is from one of our caregivers. Like, my sister's ACC trachea cancer has spread to her lungs. Like, do I therefore have a medical family history of lung cancer? And does this letter exclude metastasis?
A very important question. Now, just to quickly say, ACC, or adenoid cystic carcinoma, is a very rare cancer. It can happen in the salivary glands or in the trachea. It is usually a head and neck cancer, but yes, can be found in the trachea. It is often treated with local treatment, surgery if possible, or removal, or a combination of chemoradiotherapy to keep it from spreading to other parts. If it has spread to other parts, then it would be treated as a sort of any metastatic stage 4 cancer with controlling it. In terms of the question to family history, the answer to that is no. ACC is not one of these cancers that are part of what we call a predisposition for hereditary cancers. Dr. Tan mentioned prostate cancers and BRCA2, and this is sort of part of the hereditary breast ovarian cancer syndrome, which includes ovaries, breast, prostate, and pancreas. And so this sort of group of people who have this mutation in their germline, it may be passed on, and increases the risk of these particular cancers to occur at an earlier age. So ACC per se is not part of these groups.
And a follow-up question about family history of lung cancer. If my family has a history of lung cancer, what extra precautionary measure should I do to prevent this?
Again, another very important question. When it comes to a family history for lung cancers, we don't have many mutations. In such, there is only one sort of potential mutation or genetic abnormality. We call this T790M if it's detected at the first time of diagnosis. It is not very common, And therefore the familial cases for lung cancer are mainly probably occupational or environmental or factors that we are not quite clear yet as to why they are. What to do to prevent it essentially is the same preventative measures we've already been mentioning: healthy, balanced diet, do not smoke, exercise, and follow the sort of guidance as per Singapore healthcare professionals to stay healthy and avoid sugary things and the processed meat.
Thank you, Dr. Jens. As we talk about family history, it's like frequently being mentioned in different contexts and presentations. And I would just like to clarify with the question from our audience, what does family history exactly means? Does that include paternal and maternal uncles, aunties and grandparents, or is it just parents and siblings? What do you think, Dr. Tan and Dr. Jens?
So I think family history will include anyone in your bloodline. Obviously, if you're someone who's adopted, it doesn't apply. So anyone in your bloodline, including your uncles, aunties, grandparents, siblings, they all will be part of the family history.
Anything to add, Dr. Jens?
Yeah, we have first-degree relatives, second-degree and third-degree relatives. So the most important question is its first-degree relatives. So our parents, siblings, and children would be the first sort of family members to ask about if they've had cancers. And then, of course, when a person has a suspicion of a hereditary cancer syndrome in their family or through a cancer diagnosis, then this can be followed up in what we call genetic counseling clinics, which is a clinic that looks deeper into the family tree, where we look into the second and third degree family members to see what potentially may be passed on through the family.
Thank you. Next question is related to prostate cancer screening. Dr. Tan, how can we check for PSA level to determine the need for MRI? Do we go to the polyclinic?
The good thing is that a PSA blood test is done by almost all labs in Singapore. So you can get a blood test done by seeing your family physician, your GP, or it's also available in the polyclinic as well.
Okay. The following question is from a stage 4 lung cancer patient. Dr. Jens, perhaps this question is for you. Having been experiencing numbness on the person's left arm during sleep whenever he or she lies on the right or the left side, and the oncologist said that it's unlikely the cause from the chemo treatment. Like, from whom should I seek advice from? And perhaps I think the biggest question is, how do we better manage the physical symptoms that the patient have?
Yeah, thank you. So numbness sometimes can be caused by chemotherapy, and we would call this, the fancy term is peripheral neuropathy, similar to people with diabetes. So they can have numbness in the hands and feet. And that is sort of from the symptoms just described by the person who asked the question. In the left arm, it's not quite chemotherapy related. So I think in this aspect, the advice from the oncologist to say it's unlikely to relate to chemotherapy is correct. What best to do, it may be that this is a symptom that comes from the neck. There may be sort of a spondylosis, which is a sort of a weakening of the spine in the neck, which is pressing on the nerves. It may be another process that is not related to the cancer or its treatment, and may just simply need a X-ray of the neck, or maybe a further scan of what we call MRI to see, is there a nerve impingement or some changes within the discs as such. So where to go? See polyclinic, or get referred to an orthopedic surgeon.
Thank you. Next question is about prostate cancer. It's also about screening. So as part of the health screening, sometimes there is prostate ultrasound screening. Is it beneficial in detection for prostate cancer early?
Okay, so as I mentioned previously on the ultrasound, unfortunately the images are not of good enough resolution. Very often the cancer can not be seen clearly on the ultrasound. So it is not beneficial for prostate cancer screening. It gives us an idea of the size of the prostate. We do know that prostate size increases with age. It may lead to urine symptoms, but for prostate cancer screening per se, it's not beneficial.
And just a follow-up question related to screening as well. How often should we do antigen test for the prostate?
Okay. So with regards to the PSA blood test, if your blood test is normal, usually this would not trigger further investigations. The doctor will usually advise you to repeat it perhaps in 1 or 2 years' time, just to monitor whether there's any changes in the PSA level.
Okay. The next question is related to physical exercise. I think it's specific to prostate cancer, but perhaps we can also invite Dr. Jens to chime in for lung cancer. So is there any physical exercise that you would recommend to stop or alleviate cancer in general and delay the onset?
I would say maybe the physical exercise helps in a sense that because one of the risk factors for prostate cancer is being overweight, being obese. So exercise will help as part of the approach to reduce weight, to keep a healthy weight. And by having a healthy weight, it will reduce the risk of prostate cancer. But even with cancer patients, good exercise keeps them fit to be able to go through whatever cancer treatment they need. So exercise is beneficial.
Dr. Jens, do you have an opinion about exercise?
Yeah, it's pretty much as what Dr. Tan said. I mean, there is no specific exercise for a particular type of cancer that one should do to help prevent or can do. It is generally being active, sticking to the physical or the recommendation in terms of reducing weight. And if a person is healthier, they also are able to cope with the side effects of a treatment that is necessary. So in a way, it's just SG, healthy SG, follow it and get moving, essentially.
Dr. Jens, we talked about in this part of the world, in Asia, quite a lot of the cancer patients are actually non-smoker. Do we actually know the main cause of lung cancer in non-smokers?
Yeah, again, another very important question. The Solstice trial, or project, I should call which we've mentioned, is one of these things that is locally done. It is done in conjunction with the NCCS, and we want to figure out, can we find biomarkers, blood tests, DNA tests, EGFR mutations, or one of these sort of things we know that do drive lung cancer in non-smokers. Can we find this as a cause here, and can we detect lung cancer early? So in a way, we don't know yet. Yeah, there are lots of sort of suggestions. We mentioned the cooking fumes. We mentioned secondary smoking is a different issue, but we mentioned the mutation. So we don't know yet, but this Solstice trial will hopefully help to find some answers to this question. So if anybody on the webinar is interested to participate in this screening program for lung cancers, please catch the QR code and see the clinic.
In fact, this is really an evolving field to be discovered and to be understood. And if you want to be part of this development in terms of understanding what is the main cause of lung cancer, please remember to participate in the Solstice project that Dr. Jens is mentioning just now. Okay, next question is about prostate cancer. Does undergoing frequent cystoscopy help detect prostate cancer early, Dr. Tan?
Okay. The simple answer is no, but what is a cystoscopy? So cystoscopy basically means a urologist putting a camera or a scope up the penis in men to visualize the urine pipe all the way to the bladder. Just now in my talk, I showed that the prostate is part of the urine tract. The urine pipe passes through the prostate. So, you only visualize this part of the prostate which is within the urine pipe. Unfortunately, prostate cancer usually arises in the periphery, on the sides of the prostate. So this is not visualized on the cystoscopy or on the scope. And I would say the cystoscopy is not useful to detect prostate cancer early. It's mainly to detect problems with the bladder, including bladder cancer, but not for the prostate.
Thank you. And Dr. Jens, just now you've showed some statistics related to like the different stages of cancer for lung cancer. What is the survival rate for lung cancer that are in stage 3 or stage 4?
Yeah, I will avoid percentages because it depends on many factors. So the staging, although we say 3 and 4, we do have other ways of subdividing it, which may have an impact onto the prognosis of that particular person. Stage 3 often is being treated with a curative intent. So the options we have is surgery, or give treatment before surgery, or give treatment after surgery with the curative intent has been performed. In stage 4, it is of course given to control the cancer. How long that control will be, again, depends on the underlying cause. If we have a person with a EGFR-driven mutation that can be treated with a oral sort of targeted treatment, then the expectancy is better or longer, as if it's just chemotherapy. But if we can use chemotherapy plus immunotherapy or a different combination, these things depend on the specific circumstances. So I try to avoid putting numbers on this question, if I may.
Thank you. Dr. Tan, for early prostate cancer, is it true that there's no need to treat, but just to continue to monitor? And if it is so, does it mean that intervention is only required when cancer progresses further?
So I think this depends. This depends mainly on the grade of cancer. We have talked a lot about the stage of cancer, which determines whether the cancer is within the prostate or whether it has spread. So for early prostate cancer, it means the cancer is only found within the prostate. So that's when the grade is important. So grade is, in essence, how aggressive the cancer is. And for prostate cancer, it's usually divided into grade 1 to grade 5. So grade 1 cancer is considered a very slow-growing cancer. Some studies have shown that the risk of growth, risk of spread is almost negligible. So I would say that if you have early prostate cancer that is considered stage 1 cancer, most of the time nowadays, most doctors will tell you we can monitor. There is no need to treat unless during the monitoring process there is evidence of cancer growth. But for the more aggressive forms of cancer, for the prostate, the recommendation is still to consider treatment.
Thank you. Dr. Jens, for lung cancer, I understand for now, according to the person who submitted the question, is preliminary test is an X-ray. Does any blood test help to check? And if X-ray is clear, but the person is still coughing for a few months, what other tests can that person take?
Yeah. So yes, a chest X-ray is a preliminary test or an easy one to do. If it is all clear and the cough is persistent, then it would be probably better to seek medical help more frequently, polyclinic or a GP, or be referred to a respiratory physician, either in this restructured hospital or in a private clinic, to see, is this cough due to, let's say, a developing underlying lung problem, asthma or chronic bronchitis, or something like these things that are not easily detected on a chest X-ray. A chest X-ray is a simple screen, but doesn't give too many details, so further tests may be needed in this sort of situation.
So just a follow-up question. So can a normal X-ray detect potential lung cancer then?
Right. I think a normal X-ray would say there is nothing to see, so we would have excluded potential cancer. But the difficulty with this is that the resolution of a chest X-ray is not as good as a low-dose CT, or not as good as a CT with contrast, or as a CT that we call high-resolution CT. Now, these different sort of imaging modalities are part of what is given in terms of contrast, and the thickness of the slides of how many sort of X-rays one takes throughout a person's lung. So the 1 millimeter or 5 millimeter sort of slices in the CT scanner or computer tomography scanner sort of may miss what is in between a 5 millimeter slice. So if the nodule is 4 millimeters and you just happen to have a 5 millimeter slice and misses this one, then a CT may miss it. So in a way, a normal chest X-ray would not detect potential cancer, because to have a chest X-ray showing a lump, it would be sizable. But if it's too small, then a chest X-ray would be passed as normal, because it can't be seen.
Thank you, Dr. Jens. The next question comes from a prostate cancer patient. The prostate cancer patient has completed prostate radiation therapy as well as hormonal therapy about 8 months ago. And he's now straining and have urine retention and nocturia issues. Some straining and delayed urine dripping. Are these indicative of possible reoccurrence of his prostate cancer?
These symptoms alone are probably not a sign of reoccurrence of the prostate cancer. The better test to check whether the cancer has come back is still the PSA blood test, which should have dropped significantly after radiotherapy, and only if it's significantly risen after that, then it's a sign of recurrence. These symptoms that the patients face are probably a combination of two things. We know that as men age, we have a benign prostate enlargement. This can lead to all the symptoms that have been described. Also possibly some of the radiotherapy, because although it's focused on the prostate, there can be some collateral damage to the bladder. It may lead to some issues of urination as well. So it's probably more likely to be due to his benign prostate enlargement, possibly some side effects from radiotherapy, and is not indicative of possible recurrence of prostate cancer based on this.
Thank you for being so reassuring, Dr. Tan. Next question is related to lung nodules. Dr. Jens, if existing lung nodules have increased in sizes or numbers, should a follow-up low-dose CT be done annually as a follow-up?
Yeah. The reason why low-dose CTs are done is to find these nodules that are increasing either in size or numbers. And if that is the case, then one would want to proceed with what we call a biopsy. Dr. Tan has explained how the prostate biopsies are done. In lung cancers, we would use our interventional radiologist to help us get a tissue out of one of these lung nodules in a safe way. So if these numbers or nodules are increased in size and number, then probably a biopsy would be recommended to make sure it's not cancer. Or if it is cancer, it is diagnosed at an early stage.
Thank you. The next question is a cross-cancer question. For prostate cancer that spreads to the lungs, will it behave similarly to lung cancer, and will it be treated as normal lung cancer? Just wonder if both of you have an opinion?
Okay, so I think that's where the biopsy comes in, because it's very important to know where is the origin, where is the primary cancer. Treatment is actually very, very different. Just as an example, for prostate cancer that has spread anywhere else in the body, the main treatment is what we call hormonal therapy. The main driver for prostate cancer growth is our male hormone testosterone. So the main treatment nowadays is a combination of injection as well as tablets to control our testosterone levels to shrink and treat the cancer. Some men may be treated with some chemotherapy as well. But the treatment for lung cancer is completely different. So lung cancer, you will never ever treat it with hormonal treatment.
And Dr. Jens?
Yeah, same. So it's if a prostate cancer spreads to the lung, it'll be treated as prostate cancer. If a lung cancer spreads to the bones, it'll be treated as lung cancer. So the importance is to know where is the origin, or which cell has gone wrong in which organ.
And the next question is about lung cancer symptoms. Just now, Dr. Jens, you have shared some symptoms of lung cancer, and one of them is cough of more than 2 to 3 weeks. If one has been coughing frequently, especially in the middle of the night, late night, is that a sign of early lung cancer?
Okay. probably not. But if it is ongoing, then medical help would be recommended. What it could be is it's either sometimes depends on the age of the person who's having these symptoms. If we get older, our heart may not be so good anymore in terms of pumping the blood around, so we may get this sort of issues, or there may be a different lung condition like asthma or COPD that is developing, which may cause these symptoms when lying flat. So it is not a sign of lung cancer per se, but the same sort of approach should be done. If it doesn't go away, or indeed gets worse, then investigations should be done, and that's best done through GP, polyclinic, or in this case probably respiratory physician.
Thank you. And Dr. Jens, is CEA marker a good indicator for early stage lung cancer?
No. CEA is a tumor marker, so it's a blood test, and it's a non-specific marker. Most of these blood tests that we have currently, PSA is a bit more specific, prostate specific antigen, but CEA is mainly seen in bowel cancer, colorectal cancer. It can be seen in other types of adenocarcinoma such as the lung, but it's not an indicator for early lung cancer. Indeed, it's not an indicator for any lung cancer. If it's been tested for any reason, sometimes it's done as a health screen, and this is questionable to do, because if there is no cancer, then these sort of things should not be checked as part of a health screen, because they may lead to investigations for issues that are not warranted. So if it has been done and the CEA is high, then it would lead to, or would have to be followed up, and may need to have scopes like colonoscopies, scopes into the stomach, and further sort of investigations, but it's not specific to any type of lung cancer or cancer.
Thank you. And Dr. Tan, how do I check early enough if I have prostate enlargement? I guess the question is related to how can I check early enough to detect prostate cancer?
With regards to prostate enlargement, unfortunately for men, it is a very common thing that as we age, especially past 50 years of age, we will develop prostate enlargement. Most of the time, the general advice is that we don't routinely check for this unless you do see a doctor because you already have some form of urine issues. Similarly, I would say that, if you were to screen for prostate cancer, there's no screening program in Singapore. You can discuss with your doctor once you lie in the correct age group. Typically, is from about 50 years of age.
A follow-up question also related to screening. What is the accuracy for PSA marker test? Is it able to detect prostate cancer in the early stage? And what is the next screening or next test to validate that there are no signs of PSA?
So as with most of these cancer marker blood tests, it is not perfect. For example, on the lab test, when we do a PSA test, the normal range is typically 0 to 4. We consider PSA to be a little bit high when it's between 4 to 10. So actually the risk of finding cancer when a man has a PSA to 4 to 10 is only about 20 to 25%. So you can imagine it is not perfect, especially if your PSA is only mildly elevated. So that's why, even the guidelines, the recommendation is that if you do have a mildly elevated PSA, the next test is usually an MRI scan for us to find whether there's any suspicious growths within the prostate. And most of the time, if the MRI is normal, we can probably tell the man that he's got very low chance of having a cancer. He doesn't need the next test, which is a biopsy.
Thank you, Dr. Tan. Next question is about family history again. Obviously, we have quite a lot of our caregivers that's online. And in terms of family history, do we consider secondary cancers, that means the cancers that have spread beyond their primary cancer location, as family history, or do we only consider primary cancer as part of the family history? Dr. Tan, do you want to take this question first?
So I think in the end, it goes back in a link to the previous question. You always mainly consider where the primary cancer is. When we talk about, the family history. So I think the primary cancer is the more important one. Of course, the secondary cancer is whether the cancer has spread when it was diagnosed or in the cancer evolution. So the primary cancer is more important.
Dr. Jens, do you have anything to build?
No, essentially, no.
Okay.
Yep, thank you.
Okay, another question is about sugar. There's obviously there's a belief that sugar and cancer is related. So, Dr. Jens, what is the reasons for sugar avoidance, and is it to prevent obesity, which can lead to health issues, or is it meant to starve the cancer cells?
Okay, so yeah, it's a very good question, very common question. It just keeps coming back on the internet or very soon on AI-driven platforms. It is part going into the ketogenic diet, or sort of going down this idea that cancer needs sugar in order to grow. It is a myth. Cancer does not need sugar to grow, and we can't starve cancer by withholding sugar within a ketogenic diet or similar sort of diets. The cancer cells will use whatever is available in their environment to grow. The reason why I've mentioned before avoid sugar is mainly the first reason is to stay healthy. Sugar is a cause of lots of things. Diabetes is the first one to mention, and the more sugar we have, the more we just basically put this into storage, and the storage will be in places where we don't want to have storage, and this usually leads to sort of overweightness. So I think in the way it is there to reduce the sugar intake. There is way too much in all these sugary drinks and the fizzy drinks as it is. So avoiding it leads to a better health, I believe, but it has nothing to do with starving cancers or basically treating cancer.
Thank you for clarifying this myth. We need to make sure ChatGPT also answers it in the same way. Otherwise, this myth will continue. So, Dr. Jens, just now you talked about there's some overlapping between TB and lung cancer. Does TB lead to lung cancer?
Per se, no, but it can mask lung cancer. So there's this sort of idea infections may lead to inflammation. Inflammation as such may lead to development of abnormal cells. Abnormal cells lead to cancer. So in a way there is evidence that this is true in terms of inflammation, but there is no direct evidence that tuberculosis as a bacterium per se will cause lung cancer. It's more commonly seen as masking it.
Thank you. And the next question is about prostate cancer. So, Dr. Tan, there's this patient who just did an ultrasound on his prostate. He's 65 years old. There's no enlargement noted, and there was intraprostatic calcification, and the blood test is normal. What should that person do about the calcification?
Okay, so this calcification that are seen within the prostate on ultrasound is a fairly common, what we call incidental finding. Sometimes it can be from previous infections and scarring, but sometimes is present on the ultrasound. It is not associated with a risk of cancer. Usually we would leave this alone.
Okay, so nothing to be worried about?
No. Yes, okay. Nothing to worry about.
Good to know. And the next question is, again, going back to the lungs. Is regular shortage of breath a concern of lung problem? And what kind of consultation is needed?
Yeah, so breathlessness is a potential symptom of cancer or lung cancer, but it's not the only or symptom for an underlying cause. It depends on how long it's been there. Is there another medical history that has led to the breathlessness, like heart issues or other different underlying lung diseases? And if that is the case, then that is probably explained. If that isn't the case, then the consultation should be again with GP, polyclinic, or a respiratory physician to see are chest X-rays or other investigations needed. And
Dr. Jens, there's a lady in the audience have done radiotherapy for the left breast a few years ago for early stage breast cancer. Does this increase the risk of developing lung cancer? And should that person be concerned about monitoring for lung cancer?
Yeah. Yes. I've mentioned that people who've had radiotherapy for other medical reasons or cancers in the past have an increased risk of lung cancer. It is true. For early breast cancer, where there were only 5 sessions of radiotherapy, that risk is relatively low. The follow-up for breast cancer will be at the breast cancer clinic. And unless there are symptoms, there probably isn't a need to specifically look for lung cancer for this person. Should low-dose CT be done unless the person is a smoker? The answer is no. But there shouldn't be any sort of extra tests for this.
Okay. And the next question is also related to lungs, lung nodules. Does one member of the audience have solid lung nodules size largest 5 mm detected from CT scans of lungs? What are the follow-up actions recommended, Dr. Yan?
We have what we call a lung tumor board, and this is a sort of board where radiation oncologists, medical oncologists, thoracic surgeons, respiratory medicines, doctors, amongst others, sit together and discuss cases like this, where there is a person who has a small nodule on a CT scan, and then we look at what does it look like, has it grown over time, if there is a follow-up, and the usual sort of recommendation would be just follow it up again in a year's time if there is no change.
Okay, the next question is also related to screening. It's a question to both of our doctors. Is there such a thing as having too much screening? And is there any side effects of such practice? Dr. Tan, do you want to take this question first?
I think there can be too much screening. You cannot be living in fear of getting cancer all the time. You should have a proper discussion with your primary physician, your family doctor, your GP, because most of the cancer screening, are at best, maybe once a year. So it's always good to talk to your doctor. He will advise you what screening may be necessary, what from certain ages, and that's the best advice I can give. Yeah.
And Dr. Jens?
Yeah, same. I don't think there's anything extra from my end. That is very good advice.
Yes. So go with the doctor's recommendation. Don't worry too much and just stick to it. Okay. And the next question is related to radiation therapy. Will radiation therapy increase risk of recurrence of lung cancer after treatment, Dr. Jens?
Very good question. And well, we mentioned that radiotherapy may increase the risk of lung cancer. Does it increase the reoccurrence or relapse of lung cancer in a patient who has had radiotherapy for the treatment of lung cancer? We do see this, but it's more commonly thought, or actually more likely to be due to the cancer itself, not or having responded to the original radiotherapy for some time and then started to grow again, as in developing resistance to the treatment. So it's less likely, and I wouldn't worry about this to be the cause.
Okay, we have 3 more minutes left. Probably we should go to the final 2 questions. Dr. Tan, for prostate cancer, we didn't talk too much about treatment options. Is surgery or radiotherapy better?
Okay, so when we talk about surgery or radiotherapy, it is usually for cancer that is within the prostate, which is an early prostate cancer. The short answer is that actually the cure rates or the success rate is the same in most cases, whether you choose surgery or radiotherapy. Surgery nowadays is usually keyhole surgery done with the robot. We make 6 small cuts on the belly to do the surgery. And in surgery, we remove the entire prostate. So for radiotherapy, as mentioned, usually they are using very strong X-rays to treat the entire prostate. So in both these treatments, the entire prostate is treated whether by removing it with surgery or radiotherapy. It is a very long discussion, I would say. Usually in the clinic, we spend half an hour, even an hour talking about the options. The key thing, I think, is that to consult your doctor, and eventually, most of the time in most hospitals, patients will see both the surgeon, the urologist, as well as the radiotherapy doctor, the radiation oncologist, because I think by understanding both options, can you make the best decision because essentially it is a personal choice, and most of the time there is essentially no difference in terms of the success rate.
Okay, perhaps we can take one very last question. Immunotherapy is a relatively new therapy in the arena of cancer. So does immunotherapy helps with prostate cancer and lung cancer?
So for the prostate, unfortunately, for now, there is no good evidence of the usage of these are newer forms of immunotherapy for prostate cancer, except for a very, very select subgroup of patients. But I think I will not dwell on those rare cases with certain mutations. Yeah.
Okay.
Yeah, for lung cancer, it is a standard treatment option, and it depends on various different biomarkers to see, can we give immunotherapy on their own as a monotherapy, or do we have to give it with chemotherapy combined? The way we think immunotherapy works is that it reboots a person's immune system that in a way has gone to sleep, accepting the cancer is there, and lets the cancer do what it is. So in a way, it is like a computer that is frozen, and you restart the computer. So in a way, the immunotherapy will reboost or restart the person's own immune system to recognize the cancer as foreign, and then mount an immune response to treat it or get rid of it.
Thank you, Dr. Yan. And thank you, Dr. Tan. Just now in our Q&A, we've answered 35 questions. That's actually quite a lot of questions. And in fact, it was a very insightful session today. I've personally also learned a lot from our two doctors. And a big thank you to our speakers, Dr. Jens and Dr. Tan, for sharing their expertise on lung and prostate cancer today. I'm sure our audience also learned a lot about lung and prostate cancer, as well as the tips to spot, help, and care for both patients and caregiver. If you would like to participate in the Solstice Research Program for lung cancer, the research program that Dr. Jens has mentioned probably 3 times in today's conversation, you may scan the QR code to learn more later. The QR code will be shown very soon. And once again, before we end, we would like to thank our sponsors, Daiichi Sankyo, AstraZeneca, and Bayer for supporting the webinar today. Lastly, we would like to thank you all for your participation in today's webinar. We have now come to the end of Singapore Cancer Society's Prostate and Lung Cancer Awareness Webinar 2024. Thank you for joining us this morning, and please help to complete the feedback form by scanning the QR code that's shown on the screen so that we can do better. And for more information on SCS Cancer Screening Initiative and other programs, please visit their website at www.singaporecancersociety.org.sg or call 1-800-727-3333. Thank you all, and see you in our next webinar. Have a great weekend.